Good morning, everybody. I am Dr. Kanhu Charan Patro, neuroradiation oncologist. Today, I am going to tell about how to handle a newly diagnosed brain metastasis case. Brain metastasis is not uncommon. It is regarded as a stage 4, but still there is a good survival in good cancer. So even 5 years survival is good. So let's see how to handle brain metastasis case in better way. So if you see the options for the brain metastasis, we can observe, we can go for the surgical indications, we can go for radiation indications. In radiation indications, whether we can go for a whole brain RT or stereotactic radiotherapy, either in form of single fraction, multifraction, and post-op cases, post-op cavity radiotherapy. So to understand this, we have to follow some guidelines. In these guidelines, ASCO, SNO, and ASTRO guideline is published few days back in JCO. Another guideline is ISMO guideline published in Annals of Oncology. Another guideline from IASSLC, International Association of Studying Lung Cancer, how to handle the in targeted therapy era. Another guideline from the multiple brain metastasis the radiosurgery from the Pittsburgh. So if you see the radiation part, we have three options. We have a stereotactic radiotherapy, we have a whole brain radiotherapy, or we have a whole brain radiotherapy with hippocampal evidence. Either patient may be symptomatic or asymptomatic, maybe good KPS, good performance status, or poor performance status. So we will discuss the problems and solutions in the form of questions and answers. My first question: brain MRI screening for newly diagnosed cancers. So if patient comes to you, we should screen for the all brain MRI for brain all patients or few patients. We should not screen, but we should screen for patients with lung cancer with except stage 1 NLCC. We should consider for the stage 4 melanoma and patients with metastatic HER2 positive and triple negative breast cancer. The presence of brain metastasis should be explored by neuroimaging in all patients of cancer who present with clinical symptoms. Whether patient is symptomatic, definitely you have to do. If patient is asymptomatic, in case of all stage melanoma cases, small cell lung cancer, metastatic HER2 positive, metastatic TNBC, and NLCLC except stage 1. Whether we should go for a whole brain RT or any other thing, or we should not recommend a whole brain RT. In post-operative setting, if you we have done for the cavity surgery, brain met surgery, so you should not go for the whole brain RT. You should consider SRS. And if there is a multiple brain metastasis not amenable for surgery or SRS, better go for a whole brain RT. But it depends upon the size, number, location, and availability of the systemic therapy. Supportive care with omission of whole brain RT when there is a poor performance status. PCI is still recommended when in extensive SCLC with complete response, even in limited stage when there is a complete response to chemoradiotherapy. Who should receive memantine and hippocampal evidence during whole brain RT? A patient having no hippocampal lesion, no lesions within hippocampal evidence zone, and you are expecting 4 months or more expected survival, you should go for a hippocampal evidence during whole brain RT. When we should plan for SRS alone, opposite to whole brain RT, SRS alone should be offered patients with 1 to 4 unresected brain metastases. SRS is recommended for patients with a limited number of metastases like 1 to 4. Patients with a higher number of metastases, you can go like 5 to 10 if the cumulative volume is less than 15 ml. SRS to the resection cavity is recommended after complete or incomplete resection of brain metastases. When should not we plan for SRS alone, even in 1 to 4 mets? When there is a small cell carcinoma lung where there is high chance of brain metastasis, you should not go for the SRS in the small cell lung cancer patients. You can plan SRS after whole brain RT when there is some persistent lesion or some recurrent lesion after whole brain RT after long interval. Suppose you are planning SRS, your volume 12 gray volume is more than 10 cc. What is the next thing we have to do? You should go for a fractionated SRS rather than single fraction SRS when your 12 gray volume is more than 10 cc. So when there is more than 10 cc 12 gram volume is there, you should go for a fractionated SRS, and this is the you can go for a 30 grain 5 fraction or 3 fraction schedule where you should keep your 10 cc volume 30 grain. Can you use radiation sensitizing agents with Holbein RT? No, there is no recommendation and no guideline to use radiation sensitizing agents with Holbein RT. What are the SRS radiation dose schedules according to the RTOG guideline? If there is a lesion is less than 2 centimeter, you go for 20 gray to 24 gray single fraction. If patient is 2 to 3 centimeter, you go for 18 gray. For patients with intact brain metastasis more than 3 centimeter to 4 centimeter, you can go for the 15 gray single fraction. Shall we consider performance status when considering Holbein RT? Yes. So when there is a performance status is less than 50, or when performance status is less than 70, no systemic therapy options. We should not. You should give whole supportive care only. If Holbein RT is utilized, brief schedules. If you are thinking of better to go for Holbein RT, better go for the brief schedules like 5 fraction, 20 gray 5 fraction schedules comparing to the long course schedule. Can you avoid radiation in asymptomatic brain patients? You can avoid if targeted agents available with good CSF penetration, you can avoid. Let's take some example. What are the targeting agents? You can see breast is the HER2 positive, non-small cell cancer, EGFR, ROS, ALK positive, melanoma, BRAF positive. Some other targeted agents are there, but mostly we utilize breast, melanoma, and lung cancer. So if you see in a EGFR and ALK positive tumors, when there is a brain metastasis, if you treat with radiation and TKI alone, radiation and plus TKI, the survival progression probability is the same whether you go for TKI or TKI with Holbein RT. So either time to any progressive disease or time to CNS progressive disease, the survival is same. There is no significant difference. No, actually not survival. It is time to CNS progressive disease. It is almost same. So find out the targeted agent. If there is a targeted agent available, better go for the targeted agent rather than Holbein RT. So let's some example. Osmartinib or icotinib for the EGFR mutant NSCLC, alcitinib, brigatinib, seritinib for ALK rearranged NSCLC, pembrolizumab. If you are going for pembrolizumab, if there is a PDL1 positive and immunotherapy naive patient, you are using permetrexate platinum agent, you can use pembrolizumab. Ipilimumab and nivolumab patients with BRAF, regardless of BRAF status, and dabrafenib, tramitinib in patient with BRAF mutation in with brain metastasis with melanoma, asymptomatic melanoma. Combination of tucatinib, trastuzumab, and capecitabine may be offered patient with HER2 positive metastatic breast cancer who have asymptomatic brain metastasis and or progressed on previous trastuzumab, pertuzumab, or trastuzumab based therapy. If the agents are used, local therapy may be delayed until there is evidence of intracranial progression. So these are the 5 conditions you can defer the whole brain radiotherapy after you can defer the whole brain radiotherapy if patient is asymptomatic brain mets. Should all asymptomatic receive radiation? All symptomatic patients receive radiation. Patients with symptomatic brain metastasis should be offered a local therapy, either form of radiosurgery, radiation therapy, surgery followed by SRS, regardless of systemic therapy used for systemic disease. If patient is symptomatic, you should plan for the whole brain RT. Who are the candidates for the surgical resection? So, surgical candidates for brain mets. Every patient should not go for a surgical resection, but when it is compressing the vital structure like optic chiasm, brainstem, if there is a gross mass effect, if there is a large cystic met, if there is a carcinoma of unknown primary, where brain met is the only site for the histology, we should go for, in these four conditions, you should go for the surgery for the brain mets. Otherwise, surgical surgery is not not indicated. What type of radiation should be offered to patients who is undergone resection? SRS alone should be offered to patients with one or two resected brain metastases if the surgical cavity can be safely treated considering the extent of remaining intracranial disease. So, what are the post of cavity SRS schedules? If there is a less than 4.2 cc, go for 20 gray single fraction, 4.2 to 8 cc, 18 gray, 8.8 8 to 14.4 cc, 17 gray, 14.4 to 20 cc, 15 gray single fraction, 20 to 30 cc, 14 gray, and 30 to less than 5 centimeter max, you can go for 12 gray single fraction. If there is a cavity is large, better go for the 30 grain 5 fraction. This is the most acceptable schedule. Remember, always when you are doing the cavity radiosurgery, post op cavity radiosurgery, always remember A, B, C, D, E. A for adjacent dura, B for bone flap inner part, cavity proper, dural enhance, and enhancing component. These 5 things should be included in your target volume. So don't forget these 5 things because the recurrence pattern is based upon this. When we should SRS treatment for after cavity radiosurgery? The cavity, usually after cavity radiosurgery, we should start treatment within 4 weeks. But remember, we have even during SRS, the cavity takes time to the stabilize. So if there will be a mismatch, if you do an early cavity radiosurgery, so early imaging, so cavity stabilization after 3 weeks and take an MRI after 3 weeks and start treatment within 4 weeks. So SRS cavity SRS should be done within 4 weeks and take imaging after 3 weeks and match with CT scan and plan for cavity radiosurgery. How to handle the patients with raised ICT? Remember DREAM protocol. Dream protocol is nothing. DEXA, ranitidine, eptoin, antiemetic, and malitor. Eptoin or anti-epileptic. So this known as a DREAM protocol. What we follow regularly this week. Even you can go for DEXA till 32 milligram when the patient is not responding. Use of steroids and anticonvulsants. Steroids should only be considered if patient is symptomatic. Patient is asymptomatic, don't go for steroids. Primary anticonvulsant prophylaxis should not be given. But in my practice, I give levetiracetam to even patient is not no episodes of seizures, because levetiracetam is very safe drug and it can prevent unwanted events. If indicated, low molecular weight heparin should be considered as the first line treatment for primary and secondary thromboprophylaxis and for the therapeutic treatment of VT in brain met cases. Which antibiotic is good for long term? Actually, we should avoid eptoin, that is called phenytoin, because phenytoin with cranial radiation therapy causes lots of effect known as impact syndrome. It is a sometimes it is a life-threatening symptom like Steven-Johnson syndrome. Apart from that, you can use because it is a enzyme inducer. So when you are using systemic therapy, again it is an enzyme inducer. So you should avoid eptoin or phenytoin during the radiation therapy. Which novel drug is the best? So levetiracetam is the best drug when you are using as a systematic therapy or using with radiation. This is the best drug when you are even you are using. So best drug is the levetiracetam. When what is the imaging recommendation after whole brain RT or SRS? So you should go for every 2 to 3 months imaging as well as a physical examination. If patient having neurological symptoms, you can go for imaging early, and brain MRI should be carried out every 2 months or at instance of suspected neurological problems. Advanced MRI techniques, always you do the MRS and perfusion scan or amino acid PET, because it will allow to differentiate between the necrosis or progression. Always ask for a MRS and a perfusion scan. There is some few algorithm tables: limited brain metastasis, weak performance status, and large brain performance status good, and large brain tumor. If there is no large brain mass effect, go for the largest brain tumor 3 centimeter. Go for the single fraction SRS more than 3 centimeter. Yes, go for multifraction SRS. If there is a single more than 3 centimeter, go for a multifraction SRS, and less than 3 centimeter, go for a single fraction SRS. So remember, when brain mets more than 3 centimeter, multifraction; less than 3 centimeter, single fraction. If it is a more than 4 centimeter and there is a mass effect, go for a neurosurgical evaluation. If there is a neurosurgical candidate, yes, do resection, do SRS. If there is not a neurosurgical candidate, go for multifraction SRS or Holbein RT with hippocampal evidence and membrane. If there is a performance is poor, there is a C for the systemic disease. If systemic disease poor systemic therapy options, brain met symptoms control, yes, supportive care; not control, no. Holbein you can control the Holbein, give the Holbein with brief schedule. If symptom sisters absent or stable, you can large brain tumor with more than 4 centimeter, go for the neurosurgical evaluation. If neurosurgical candidate, do surgery, go for SRS post cavity. If not a neurosurgical candidate, you can go for the Holbein RT. If patient is less than 4 centimeter, you can go for the directly Holbein RT and brief schedules or consider SRS. If there is extensive brain mets, if there is echo performance study is good, go for the largest brain met 4 centimeter, neurosurgical evaluation. Like you can go for the neurosurgical candidate. If there is surgery, then go for whole multifraction or SRS. And if there is a number of brain mets is more 5 to 10 brain mets, and more than 11 mets, go for the memantine whole hippocampal evidence Holbein RT. Largest brain mets more than 3 centimeter, you can go for the single fraction. If the 12 gray volume is more than 10 cc, you can go for the multifraction SRS, and you can go for the if you are achieving 12 gray volume is less than 10 cc, you can go for the single fraction SRS. If poor performance status, if there is systemic disease with poor systemic therapy options, brain mets, poor systemic disease, then brain mets, supportive care. If there is symptoms recovered, you can symptoms not recovering, we can go for the Holbein RT. If systemic therapy absent or stable, largest brain mets more than 4 centimeter mass effect, again neurosurgical evaluation. And if there is a neurosurgical candidate, go for the resection and evaluate for the adjuvant RT. If there is a not a neurosurgical candidate, you can go for the Holbein radiotherapy, considered brief schedule. If largest brain tumor more than 4 centimeter, not a neurosurgical candidate, you can go for the Holbein RT with brief schedule. There is a Pittsburgh recommendation for brain metastasis. If symptomatic, mass effect, resection, SRS. If tumor volume less than 25 centimeter cube, SRS, you can go for the Graham treatment less than 2 hour, single fraction SRS. Again, you go for a surveillance, and if there is a tumor more than 25 cc and gamma knife treatment is getting more than 2 hours, go for the patient can tolerate more than 2 hours, you can go for SRS single fraction. If not cannot tolerate more than 2 hours, you can multifraction SRS. And if there is a miliary disease, if there is a leptomeningeal disease, go for whole brain RT. After SRS and Holbein RT, you should do every 10 to 12 weeks MRI. If a new tumor found, if there is a limited, you can go SRS. If there is a miliary disease, you can go for the Holbein RT. So thank you very much for watching my video. You can share for the benefit of the students, benefit of the society, and I pray God give the blessings to the patients who are suffering with brain mets and rigid ITC, ICT, and take care. Thank you.